My name is Thom Dahle, an interventional cardiologist at CentraCare Heart and Vascular Center in Minnesota. The case I'm presenting here is a 59-year-old male with past medical history of tobacco use, hypertension, and sleep apnea, but no prior history of coronary artery disease. He presented to our emergency room with recurrent chest pain at rest that was relieved with sublingual nitroglycerin. His initial EKG had nonspecific changes, and his troponin was positive, measured at 0.167, ruling him in for non-ST elevation MI. He underwent coronary angiography. Our first view here, an RA-O'Connell view, shows a severe stenosis in the mid-left circumflex artery with a hazy appearance and likely representative of a recent or subacute plaque rupture. Also, if you notice in this view, there's moderate diffuse narrowing of the proximal circumflex. In our cranial view, here you see moderate to severe narrowing of the proximal LAD, as well as mild to moderate diffuse disease of the mid-LAD. The remainder of the LAD is a small vessel with mild diffuse disease. Also in this view, you see moderate to severe stenosis of the mid portion of a moderate-sized branching diagonal. O'Connell view, you can appreciate the proximal circumflex disease and again the culprit lesion in the mid-left circumflex. Angiography of the right coronary artery. It's mild disease in the mid-RCA. It is a dominant vessel, and you notice there's a focal moderate to severe 60% stenosis in the right posterior lateral branch. I proceeded with intervening on his mid-left circumflex artery with placement of a 3.5 by 16 millimeter drug-eluting stent and achieved a nice result, as you see here. My question for you is, what would you do next in this case? Are the other lesions significant, including the proximal LAD, the proximal circumflex, the mid-diagonal, and the right posterior lateral? We have several options for these lesions. We could treat medically. We could use a pressure wire to see if any of them are severely hemodynamically significant, or perform follow-up stress imaging later after discharge. I think we'd all agree not to intervene on a non-culprit lesion in the setting of acute coronary syndrome in the absence of any significant cardiogenic shock or ongoing chest pain or EKG changes. I elected to perform fractional flow reserve testing of these other non-culprit lesions to determine their hemodynamic significance. I placed the patient on IV adenosine in order to reach maximum hyperemia. One advantage of using IV over intracoronary boluses of adenosine, as in this case, would be if there's multiple lesions to measure, you can simply place the patient on IV adenosine to reach your maximum hyperemia and redirect the wire across the various lesions you want to study. I began with placing the wire past my stent in the mid-left circumflex and showed no hemodynamic significance of the proximal circumflex narrowing, with an FFR of 0.99. Next, I redirected the wire into the first diagonal, and as you can see here, the maximum FFR was 0.85 at peak hyperemia, again showing no significant hemodynamic stenosis. And finally, with that FFR wire placed into the mid-LAD, measuring the significance of the proximal LAD narrowing, you see we get a significant fractional flow reserve ratio of 0.78, indicating hemodynamic significance of the proximal LAD. Next, the pressure wire was then placed across the focal right posterior lateral lesion, as you can see here, and we received a FFR value of 0.97, showing this lesion not to be hemodynamically significant. Given the presence of a hemodynamically significant proximal LAD lesion, I recommended the patient return after 1 month for a staged intervention of his proximal LAD. I placed a single drug-eluting stent across this lesion with an excellent result as demonstrated here. In conclusion, I think this case is a nice demonstration of pressure wiring non-culprit lesions during acute coronary syndrome to determine their hemodynamic significance. The usefulness of performing this during the setting of PCI of a culprit lesion is to avoid additional unnecessary procedures for the patient and help determine management going forward following his ACS. It can be a safe and useful tool to determine if these non-culprit lesions are hemodynamically significant.